an honor to introduce Dr. Silvia Mongodi, a renowned expert in lung ultrasound and an international reference in the field of intensive care. Among her numerous scientific contributions, her participation in the recent European Consensus on Lung Ultrasound stand out. A key document that sets a new standard for training, accreditation, and clinical implementations. I had the privilege of completing a fellowship with her, so I can personally attest to her professional excellence, scientific rigor, and remarkable generosity as an educator. And without further ado, please join me in welcoming to Dr. Silvia Mongodi, who will share her experience and insight on this fascinating topic. Okay.
Thank you, Javiera. It's a pleasure to see you all. And well, I hope you can see my presentation. And let's try to see it bigger. Okay.
Perfect.
It's okay? Right.
Yes.
Perfect. Okay. Continue to share, yes. It's a pleasure to see you all. It's a pleasure to see you, Javiera, after you spent so many months in Italy with us. You are already so expert in everything we are going to say, but I'm still happy we can still share one additional lecture. And we will see in the next, I would say, next hour, how we can use lung ultrasound in an intensive care. It's going to be a very quick overview because the possible applications are so many. So we are going to see just some of them. And I think that we will go through two definitions of lung ultrasound, which are the first classical application, which is qualitative lung ultrasound, which consists in identifying the ultrasound patterns like A lines, B lines, effusions that can be integrated into the differential diagnosis of acute respiratory failure and respiratory disease. While the second part of the presentation will be about a newer application of lung ultrasound in a critical ill, which is quantitative lung ultrasound, which consists in the quantification of the lung loss of aeration, which allows to not only diagnose, but also monitor the lung and also guide the treatment and observe which is the impact of the treatments we give to the patient and to personalize the ICU treatment. So let's go back to the first part. The qualitative lung ultrasound is the classical lung ultrasound you probably have in mind. So the integration of ultrasound science to improve our capacity of differential diagnosis in respiratory diseases. There is a recent expert consensus from the European Society of Intensive Care Medicine that wanted to define what is a basic competence for all intensivists working in a general or neuro-intensive care. And this went through head to ultrasound. And as you can see, we have a lot of green lights for the thorax. So there are many competencies in qualitative lung ultrasound that are considered basic. So we should all be able to recognize the pattern of a pneumothorax, of pleural effusion, and the signs of loss of aeration. So these are the patterns we should be able to recognize. From the left, a normal lung with A lines, just one or two B lines, and a normal lung sliding. The interstitial syndrome, which is characterized by the presence of vertical artifacts called B lines. A more consistent lung loss of aeration, which reach the relevance leading to a lung consolidation, which is visualized as a tissue-like pattern, and here surrounded by pleural effusion. And on the right part of the screen, a lung point coming from the right part and is visible during inspiration under our probe, which is very specific for the diagnosis of pneumothorax. So we know that if we combine the ultrasound sign in a systematic approach to our patient coming to emergency department with a dyspnea or acute respiratory failure, we significantly improve our capacity to reach the correct diagnosis early. And early means within 4 hours from admission. Of course, if we perform the correct diagnosis, we will also give earlier the correct treatment, and we will have a better use of advanced exams, which are, for example, CT or angiography. And in fact, if we apply systematically we search for ultrasound signs systematically, starting from anterior field, then moving to lateral and posterior field. As you can see, we can reach all the main causes of acute respiratory failure. Let's take the example of ARDS, which is a good example both for qualitative and quantitative lung ultrasound. The diagnosis of ARDS is a significant loss of aeration, which is normally visualized as a B pattern bilaterally, and of course also with the presence of consolidation. However, we know that we can have bilateral loss of aeration also in other diseases like cardiogenic edema or interstitial diseases, so we need to integrate the ultrasound findings within the clinical context, for example, acute versus chronic onset. And we will also look for specific findings that orient to ARDS and not to cardiogenic edema, like the presence of a diffuse but not homogeneous loss of aeration, the presence of spared areas, so normally aerated areas very close to pathological ones, and most of all, pleural irregularities and subpleural consolidation with a reduced sliding, which is very specific for ARDS. So this is the aspect that the pleura of an ARDS patient has, with very irregular margins and Hekupu region applied to the pleura that are allows us to distinguish to other diffuse loss of aeration as cardiogenic edema, where the pleura will be very thin and the sliding will be very smooth. But beyond the initial diagnosis of acute respiratory failure, sometimes we want to answer to simple questions like, why my patient is more hypoxemic than yesterday? And someone will ask you in your unit, for sure, I perform chest X-ray. And I don't know what happens in Chile, but in Italy, it frequently happens that the answer is, oh, there are areas of parenchymal consolidation or maybe pleural effusion or both. So we don't know actually what the patient has and how we should treat them exactly. While if we study the same patient with lung ultrasound, it's very easy to distinguish a consolidation, which is here the tissue-like pattern above the diaphragm, and the pleural effusion. And for example, if we take the pleural effusion, we have a very sensitive tool. We can detect up to 50 ml of fluid, and very specific. If there's no fluid at all. But we can also have from lung ultrasound examination additional information that can help, for example, in pleural effusion, in distinguishing free and complex effusion, to distinguish echogenous or anechoic effusion, which orients toward the etiologic diagnosis, and also will help us in deciding whether we should drain or not the effusion, also quantifying the amount of fluid we expect to drain. If we take the example of consolidation, here too we can have from ultrasound much more information than the simple finding of consolidation, yes or no. If we have a look to the air bronchogram. Air bronchogram are those artifacts that are visualized inside the consolidation, inside the tissue-like pattern. If you have a look to the left part of the screen, you can see that in the first image, there are no hyperechoic images inside the consolidation, so there is no air bronchogram. While in the second image, we see white spots inside the tissue-like pattern. They correspond to air, but it does not move synchronously to tidal ventilation. So in both cases, these images suggest that there is a problem with the airways, so we may need disobstructive fiber bronchoscopy or maybe physiotherapy to help the patient remove secretions. This patient may benefit from lateral positioning or prone positioning, and eventually also recruitment maneuver if we think that we are giving a too low tidal ventilation so that the air does not reach the distal lung. If we have a look to these two patterns instead, we can see that there are white spots within the consolidations. They move synchronously with tidal ventilation. So we say that the air bronchogram is dynamic because it appears and moves during the ventilation. So the airway is here patent. And if you have a linear arborescent dynamic air bronchogram, as you can see on the right part of the screen, this is highly specific for overinfection. So this patient needs a fiber bronchoscopy for microbiological sampling and antibiotics. While the other one, the punctiform one, is not specific for a diagnosis. You just know that the airflow is reaching this region during inspiration, but you have many potential treatments, like, for example, physiotherapy, recruitment, or positioning. So you can use lung ultrasound in a qualitative manner to improve your understanding of the disease of the patient and to guide some treatments. And of course, you can reassess the images and the pattern you obtain after whatever you do to improve the aeration, because the lung ultrasound is very dynamic, so the pattern changes very rapidly. So for example, if you perform it before and after a fiber bronchoscopy, you can see modification of a consolidated lung, as well as we performed together with Javiera. We performed it before and after physiotherapy, and we could see live that the aeration had improved after the treatment. So qualitative lung ultrasound is identification of the pattern. It helps understanding the underlying disease. It works better than chest X-ray. So the suggestion is use it as much as you can. It's quickly repeatable, it's bedside, it's not irradiating. What about quantitative lung ultrasound? We said that we are here switching from diagnosis to monitoring because we want to estimate the loss of aeration in our respiratory patient. We do it by the computation of the lung ultrasound aeration score, and it is considered an advanced competence. So this is not something that is expected to be done by all intensivists, but maybe someone who is specifically interested in this field, or he is specifically interested to acute respiratory failure. If you have a look to literature, you will find multiple quantification approaches, and sometimes they have been developed in different clinical settings, for example, the outpatient or the emergency department. If you work in an intensive care unit, then the approach is the lung ultrasound aeration score. And if you have a quick look comparing this score to the other approaches, you will see that it's the only one that takes into consideration the presence of consolidation, which is a very frequent finding in ICU patients, so it cannot be skipped. How do we compute the lung ultrasound aeration score? We have four stages of incremental loss of aeration, going from normal aeration if we have just A lines or a maximum of 2 B lines. Mild loss of aeration, which is 1 point, if we have more or equal to 3 B lines, well spaced, or coalescent B lines, or subpleural consolidation, but all these artifacts occupy less than 50% of the visualized pleura. The moderate loss of aeration corresponds to a score 2, and we have in this simplified pattern artifacts that occupy clearly more than 50% of the visualized pleura. And finally, we have the severe loss of aeration, which is 3 points, where we see a consolidation. So the higher the score and the higher is the loss of aeration. This is in a real patient, so 0 point normal aeration, 1 point mild loss of aeration, 2 points artifacts occupying more than 50% of the visualized pleura, moderate loss of aeration, and 3 points we see a tissue-like pattern and a consolidation. We compute this score in the 12 standard regions that we normally examine when we perform a complete examination in ICU patients. So two anterior, two lateral, and two posterior fields that are identified by sternum, anterior, and posterior axillary lines, each divided into superior and inferior. So the regions are what you can see displayed on the right part of the screen. And they are numbered from 1 to 6 and indicated with R or left. So for example, the anterior-inferior region on the left side will be L2, L3, L4, etc. So this is a way also to communicate what you found in which region of the thorax, if you understand each other, naming the regions in the same way. When we compute the score, which is computed as the sum of the regional score, so it can range from 0 when all the regions are normal to 36 when all the regions present severe loss of aeration, we know that we are reliably assessing lung tissue density when compared to the gold standard for this purpose, which is quantitative CT scan. And that there is a substantial agreement in the classification of lung ultrasound in score 0, 1, 2, and 3, and what is defined by CT as well, poorly, and not aerated, with a slight tendency of lung ultrasound to be a little bit pessimistic. So if you are in doubt between two scores, just give the lower one. Just to give you an example, this is an ARDS patient, as we can see from the diffuse loss of aeration. It involves both sides in a non-homogeneous way. It presents a very irregular pleura with big subpleural consolidations and consolidations in the posterior field. So all the features of ARDS. And this is the qualitative assessment. If you want to do a quantitative assessment, then we can compute the lung ultrasound score, and we can see surrounded in red 4 regions with a score 3. We only have 2 regions on the right side with a score 1, where artifacts occupy below or equal to 50% of the visualized pleura. All the others are score 2. So overall, we have a score of 26, which is out of 36, it's a pretty high score. How can we use this scoring in our acute respiratory failure patient? Well, first of all, the higher the score, the higher the severity of the disease. And this has been studied a lot in COVID-19 patient. There was a correspondence between the score and the lung damage as quantified by CT in minimal, moderate, and severe. And this allowed to early identify the severe pneumonia. And secondly, we can use the score to phenotype ARDS. We know that from CT scan studies that now dates back 15 years, that we can have two one is focal on the left side of your screen, and the loss of aeration mainly affects the posterior field, while the anterior fields are relatively spared. Those patients tend to hyperinflate and not to recruit when we apply the recruitment maneuver and open lung ventilation. On the opposite side, we have focal, non-focal, or diffuse ARDS. In these cases, the anterior fields are affected too, and those patients tend to have a potential for recruitment, so they positively respond to recruitment maneuver and open lung ventilation. From this second study, always from Constantin, we also know that we can personalize the mechanical ventilation approach, and the personalization consists in orienting focal morphologies to prone positioning and non-focal morphology to higher PIP titration. If we correctly personalize the mechanical ventilation and the strategy, then we can significantly reduce mortality in acute respiratory failure. But we need a very reliable tool to distinguish focal and non-focal patterns, because if we misclassify, so we apply the wrong personalized treatment, and for example, we do not titrate higher PEEP in a non-focal disease, then we significantly reduce the survival rate. And in this study, they show that chest X-ray misclassify ARDS in 20% of cases, so a very high percentage. So why not to use lung ultrasound for this purpose? Many different approaches have been proposed to use lung ultrasound to distinguish focal and non-focal, since we can use it to quantify the loss of aeration, not just in the entire lung, but also in different regions, so distinguishing anterior, lateral, and posterior ones. And the easiest approach is to compute the score in the 4 anterior fields, so the 2 anterior right regions and the 2 anterior left regions. If the score in these regions is above 2, then it means that the anterior fields are affected too. This patient is non-focal and has a potential for recruitment. So if the anterior fields are not affected, so the score in anterior fields is below or equal to 2, this patient should be oriented to prone positioning, while if it's above 2, this patient may be a recruiter, and we should perform a PEEP trial to determine which is the best PEEP level for this patient. Of course, lung ultrasound is an imaging modality. It will not tell you how much PEEP you have to set in a given patient. And what we do is to imbricate the information we have from imaging to other information we have from advanced respiratory mechanics. And in particular, in the last year, this means the study of tidal lung hysteresis in a decremental PEEP trial in order to set the lowest PEEP that allows to keep a small tidal lung hysteresis and to prevent intratidal recruitment. What about the use of lung ultrasound to monitor the effectiveness of my recruitment once I have set a higher PEEP after a recruitment maneuver? The first data come from the operating room. This is the real-time effect of a recruitment maneuver in a single region. We can see that it switches from a peripheral consolidation to a score 2, I would say. So it increased of 1 point. And there are many studies that show that an ultrasound-guided recruitment approach in the operating room reduces atelectasis and improves the outcome in terms of oxygenation and pulmonary complication in the postoperative care. But of course, in anesthesia, we are speaking about intubated patients, but normally they don't have lung diseases. They are healthy people undergoing a surgery for other reasons than lung diseases. So what about the ARDS patient, the patient with acute respiratory failure? We tried to see if we could detect recruitment with the variation of lung ultrasound score and switching from PEEP 15 to PEEP 5. And we didn't find any correlation between the lung ultrasound score variation and what quantitative CT scan defines as recruitment, which is tissue recruitment, so re-aeration of previously not aerated lung. But the explanation is very simple. For example, if you examine this region, it starts from a score 2 with a subpleural consolidation. You recruit the patient, you set a higher PEEP, and it switches to a score 0. So certainly the aeration of this region improved, and lung ultrasound detects it because the lung ultrasound score variation is 2. But in terms of CT scan definition of recruitment, this is 0% because there is no consolidation at the beginning. There is no not aerated tissue that is inflated. And at the same time, if you have a reduction in the size of a consolidation, the lung ultrasound score will continue to see a score 3, while CT scan can detect recruitment. So you are not measuring the same thing when you measure the variation of lung ultrasound score and the recruitment measured by CT. But there are other methods that can be used to measure recruitment, and they are probably more used than quantitative CT scan at the bedside. And they all measure air recruitment, which is a difference in lung tissue properties at different volumes, which very much corresponds to what you detect with lung ultrasound. And in fact, the variation of lung ultrasound score induced by PEEP setting correlate with recruitment measured by pressure volume curves, recruitment to inflation ratio, and gas exchanges. So you can use the variation of lung ultrasound score to detect an improvement in aeration induced by PEEP. Just be aware that you are not measuring the same thing that you would measure performing quantitative CT scan at the 2 levels of PEEP, which normally is done just for research purposes. Of course, you can extend your ultrasound examination to rule out complication and drawbacks of a higher PEEP setting. For example, an acute right ventricle injury, an intracardiac shunt from right to left, which can impair oxygenation, pneumothorax, as we said at the beginning, if we see appearing a lung point, and maybe overinflation, although it's not yet formally proven that there is a correlation between reduced sliding and overinflation. There are some preliminary data, and maybe we will have some more with the use of speckle tracking, but there is nothing certain for the detection of overinflation yet. Similar to what we do with the recruitment, we can also monitor prone positioning if we decided that the patient was focal morphology, and so we oriented him to prone positioning and not to open lung strategies. When we monitor the prone positioning, we will focus our attention on posterior fields. And of course, the reaeration is expected to be higher in those patients that presented a focal morphology. So a loss of aeration mainly localized in posterior fields. The reaeration happens mostly in posterior fields, and it can be seen almost immediately. So when you turn your patient, the regions that were completely consolidated sometimes appears completely reaerated minutes after prone positioning. And this was demonstrated also by studying patient early and some hours after prone positioning. And the variation in lung ultrasound score correlated with the recruitment measured by the increase in extra and expiratory lung volume measured by automated nitrogen washout wash-in technique, and also with gas exchanges. In the upper part, you see early changes, and in the lower part, you see late changes, and you can see the correlation between the variation of lung ultrasound score and the recruitment is tighter when the measurement is performed some hours later, because the more you leave the patient in prone positioning, the more the regions, mostly in the posterior part of the thorax, will reaerate. You can also use your lung ultrasound score to monitor your patient daily, and it will give you an idea of where and in which direction your patient is going, because you can see here 4 examples of ARDS patient supported by extracorporeal membrane oxygenations. They all started by very high score, and each one with its own pace. They progressively show a reduction in lung ultrasound score, which corresponds to a progressive improvement in lung aeration, and it corresponds to lung recovery. While this 5th patient, the green one, it started from very high scores and never show any significant decrease, and in fact we were never able to wean him from extracorporeal support. We are not the only crazy group doing this. There are similar results were obtained by a French group. As you can see, we are always speaking about ARDS patient on ECMO. They identified three groups: survivor, weaned from ECMO but who did not survive, and patient who could never be weaned from ECMO. They all start from similar lung ultrasound score, but after 1 week, they have very different behaviors. So the survivors significantly improved. Those who could be weaned but did not survive improved, but not as much as the previous group. And those who could never be weaned from ECMO did not show any improvement in the lung aeration. So you can monitor your patient. If the scores goes down, it's okay, the lung is recovering. What if it suddenly shows an increase, which was not expected? This preliminary cohort of COVID-19 patient was studied by another French group, and they associated the sudden increase and unexpected increase of the lung ultrasound score to new overinfection, so to ventilator-associated pneumonia. We applied this same idea retrospectively to our COVID-19 population, and we also found that the higher was the worsening of the lung ultrasound score, and the higher was the specificity for overinfection. However, just keep in mind that lung ultrasound score is a measure of density. It does not give you the diagnosis of overinfection. But if the lung ultrasound score increases unexpectedly, then you should have the doubt that there may be a superinfection, and then you can look for specific signs of overinfection, which is the dynamic linear arborescent air bronchogram, which is a very specific sign, while you have also sensitive sign like the presence of subpleural consolidation, which, however, is not very useful if you're looking of overinfection on an ARDS patient or a COVID patient, because it's already part of the ARDS pattern. So we went very rapidly through many potential applications of the lung ultrasound aeration score in critically ill patients. So from severity of the disease assessment at the beginning of the patient history, daily lung monitoring to detect recovery or early detect complications, to guide the treatment, identifying the phenotype and the morphology of ARDS, and monitoring the effects of recruitment and prone positioning. And we can also use it for outcome prediction, and for example, to guide the difficult phase of the weaning from mechanical ventilation. So there are many potential application. The literature on the topic spread in the last years, and this is what led us to try to put some order in technique and application of this quantitative approach in adult, pediatric, and neonatal critical care. So we put together a group of 20 experts coming from many different parts of the world. Some of them were either from or had experience in low and middle income countries. And we also included a respiratory physiotherapist, which is Dr. Ntumenopoulos. With the help, of course, of two non-voting methodologists. And we developed 14 clinical questions that became 46 statements, and with the aim of trying to make quantitative lung ultrasound understandable also for persons that are not expert in the field but would like to start introducing it in clinical practice. So we went through nomenclature and abbreviations, many technical aspects: how to set the machine, how to choose the probe, how to identify the regions. We defined adequate training and reliability, and we went through many clinical applications, some of which we have already seen, for example, PIP setting, prone positioning, monitoring, and also detailing some very specific application like surfactant administration, bronchopulmonary dysplasia, or pregnant patients. So, of course, we will not go through all the 46 statements now, but hopefully you will be interested in having a look to our consensus that should clarify many aspects of what we have gone very quickly through tonight. And you will see that if you apply either qualitative and quantitative lung ultrasound in your clinical daily practice, this has a significant impact on the number of traditional imaging you will need. So you will need less chest X-ray, you will need less CT scan, also when speaking about patients with acute respiratory failure. And I would like just to conclude with a very small case scenario, just to see how we can apply our examination every day. A 56-year-old man with a non-past medical history that comes to emergency department with dyspnea, with fever. We use a lot helmet CPAP in acute hypoxemic respiratory failure, but in this case it failed because he was claustrophobic. So he is admitted to ICU with a very poor PaO2 FiO2 ratio below 100, and of course is intubated for persisting hypoxemia and also respiratory acidosis. So these are the findings that are observed with ultrasound in a limited number of regions, not to overcrowd the slide. And he presented all the features of ARDS, bilateral B lines, irregular pleura, subpleural consolidation, one spared area on the left side of the chest, so normal aeration, very close to very impaired aeration, posterior consolidations, very limited amount of fluid, and also a dynamic arborescent bronchogram within the consolidation, suggesting that there was probably an underlying infection of the lung inducing the ARDS. We also wanted to compute the score. So as we saw at the beginning, surrounded in red, the regions with a score 3, and the score was 26, so pretty high. With involvement also of anterior fields, because if we compute the score in the 4 anterior regions, then we can see it's 2, 4, 6, 7, so far above the cutoff value of 2. So this patient has no focal pattern, and he was a candidate to a decremental PIP trial, recruitment maneuver, and open lung strategies. We monitor the patient daily after an initial worsening. Then we observed a progressive recovery, which was corresponding to a progressive improvement of oxygenation. This is at day 6. We can see that most of the region have reaerated. The consolidation are much smaller, so they became a score 2. This was positive response to our treatment, but the next 2 days we observe an increase in the lung ultrasound aeration score. So as we said, this could raise a doubt of overinfection, and to confirm it, you should look for specific signs. So go back to qualitative lung ultrasound and look for dynamic linear arborescent air bronchogram, and in this case, you will perform fibrobronchoscopy and antibiotics. So I'm done. I hope this interested you, and I'm here for questions if you have. Thank you.
Grazie mille Silvia, brava come sempre. Okay, now any questions? Please, because it's all information. Silvia is a great doctor. Please, questions?
Por acá, Javi.
Juan.
¿Me ves?
Sí.
Hola, hola. Bueno, Silvia. Juan
Hola.
Hola, hola. Juan Lee Goit, a physiotherapist and one of the directors of the Chilean Ultrasound Interest Group. Thank you so much, Dr. Mongodi, for your time and for sharing your knowledge and experience with us. I have many questions, but I'll start with one. What do you think about the incorporation of physiotherapies or respiratory therapies in lung ultrasound practice in critical care? How did this professional integration organize in Italy? What is your view on interdisciplinary collaboration in this field?
Yes. Well, unfortunately, we don't have dedicated respiratory physiotherapist in Italy. And I didn't have it in the ICU I worked in when Javiera arrived, and I was impressed by the effects of the work and of a physiotherapist in the ICU patient. I think that it's a professional that should definitely integrate ultrasound in its practice, because it can a lot orient the treatments, and it can also give feedbacks on the effectiveness of the treatment. So maybe the patient who needs to go on with the treatment, the patient who need to change treatment because the one who is applied is not effective. And we spoke here about lung ultrasound. The other part that probably interests a lot physiotherapists is the muscular ultrasound, so the diaphragm ultrasound, which is also something that has actually no treatment beyond physiotherapy. So we have no other treatment than training the muscle, and the only way to train it is to rely on physiotherapists to improve patient performances. So I wish we had this figure in Italy. Maybe we will arrive to have it in the future. And the interaction between intensivists and physiotherapists and the use of ultrasound in both cases, I think it can really improve the outcome of the patients.
Thanks. Second one. In your 2017 study, the transversal scan looked better for pleural visualization and reproductivity. So why wasn't it chosen as the main or standard method in the 2025 consensus?
Sorry, what you are talking about the probe?
Yeah, transversal and longitudinal difference.
Yes.
You use the transversal view, so I want to know why
the transversal view? Okay.
Yeah, consensus. Okay, that's
Well,
good.
the transversal view means align with the intercostal space. So you do not have the rib shadows covering part of the screens, and it allows to see more pleura, more artifacts. And so the suggestion is to use this scan in order to visualize as much lung as you can, because of course, if you do the longitudinal approach, the portion of pleura you can visualize is limited by the width of the intercostal space. So since it performed better in terms of visualization of artifacts and also interoperator agreement, we suggested to use this approach.
Okay, thanks. My question is, why in the last consensus is the both alternative? Because I prefer your view, transversal view, but I don't know why in the last consensus is not the recommended the just transversal scan.
Well, it is preferred. There is no comparison of longitudinal and transversal versus quantitative CT. So you cannot say this one is for sure better than the other one. There are comparisons between lung ultrasound techniques. So it's more an expert opinion than a guideline, but the expert opinion is still use the transversal scan. Of course, you need to be a skilled operator, because since you lose the anatomical landmarks, you have to be sure that you're actually looking at the lung. So for advanced operators, use transversal scan. It's the best for quantification also.
Okay. very clear. Thanks.
And
Okay,
thank you for
Silvia, Felipe Aravena
Mhm.
tiene una pregunta. Hi Silvia, thank you very much for your
Sí, yo la
presentation.
vi, yo la vi. Sí, sí.
Usted en el chat,
Sí.
ya. ¿Sí?
Idioma correspondente. Yes, we do use linear transducer in anterior and the lateral fields, and this is also what is recommended in the recent consensus, because you can visualize better the pleura. If you see better the pleura, you also see better the artifacts that derive from the pleura. Sometimes using the linear probe in posterior field is not so easy because the thickness of the parietal wall increases. And so when you go to posterior fields, you can switch to a low frequency probe. I normally use the cardiac one, but you can also use a convex one if you are more used to that. But the convex is bigger, so sometimes it's even more difficult to go in posterior fields in a lying patient.
Ok, gracias.
Yo tengo una pregunta, Javi.
Súper. Dale, Jorge.
Thank you very much, Dr. Silvia, for your presentation. One simple question. How many hours of training does an intensive care professional need to safely assess this patient?
Well,
How many hours to
this
train?
is a very important question, because of course you need to be sure what you see, and not only for diagnosis but also to guide your treatment. So thank you for the question. For the basic competencies, it is recommended to do 25 to 30 supervised exams. We are speaking about basic competencies like being able to identify B-lines, pleural effusion, and consolidations. And the quantitative approach comes after the basic level, and it's at least 25 additional exams with someone who's expert in the quantitative approach. So it's not a very long training, but of course, I think that basic and advanced should not be too close, because you need some practice in between to comfortably acquire the scan and not be stopped by technical issues while you are trying to do more advanced applications. But there is no formal definition of how much time should pass by between basic and advanced acquisitions.
Thank you very much. Para que lo tenga presente el grupo, entonces.
Buena pregunta, buena pregunta.
Buena
Eso.
pregunta, sí.
Good question.
¿Lo anotaste, Juan Enrique?
Lo anoté.
Me parece. Thank you very much.
Thank you.
No, lo mismo. Same. How many of those examinations need to be performed on real or sick patients?
I would say that, in healthy patients, the ultrasound findings are very limited. You can just identify the pleura, the A-lines, and the sliding. So you need pathological patients. I would say they should all be performed. The 25 for, let's say, certification should be all on pathological ones.
All of this with direct supervision or maybe indirect supervision? What do you think about
direct supervision? Direct supervision.
Okay. I think the same.
I think Javi did like 150 when you were here. When you have the habit to do it, it's like every patient, okay, this one is more hypoxemic, this one has opacities, this one is need to be weaned. So you really start to applying it systematically, and you will start examining all the patients you have. But in expert hand, it doesn't take too much time. This is also important. When you become confident with the technique, it requires like 5 to 8 minutes. So it really is an extension of your clinical examination. It's not too time consuming. So it's still quicker than chest X-ray and more reliable.
Sí, puede ser rápido cuando uno examina a un paciente para tomar una decisión ahí, pero cuando uno necesita hacer un examen adecuado con las imágenes correctas y viendo específicamente los detalles pulmonares que están pasando en el paciente y correlacionarlos, ahí definitivamente uno se demora un poco más porque además necesitas integración, entre otras cosas.
Claro, sí. Si solo necesitas saber si el paciente tiene o no un neumotórax, no necesitas hacer 12 regiones. Hace un
Exacto.
examen muy focused and that's it.
Silvia, from your experience in the intensive care unit, what do you consider has been the most significant change in the integration of lung ultrasound into clinical decision making over the past 5 years? 5 years.
Clinical decision making. Well, we use it a lot for lung morphology. So we really replaced the chest X-ray for these purposes, and as an integration, of course, to other instruments that we have to monitor the ARDS patient, but we rely a lot on what we see to guide the treatments. And this is something that we didn't know how to perform some years ago. Now we really decide if we should titrate higher PEEP from the patient or position the patient in lateral positioning or perform fibrobronchoscopy or insist with physiotherapy. The guidance of treatment really changed in the last years because we know better how to use lung ultrasound for this purpose.
Gracias. ¿Alguien más tiene preguntas? ¿No? Yo tengo, a ver, acá por el chat.
Saludos desde Colombia. Hola.
Yo tengo una pregunta. Sí, cuando uno recomienda reclutar al paciente según lo que uno está viendo con el ultrasonido,
Sí.
¿Cómo sé que no estoy hiperinsuflando demasiado algunas zonas que no debiese con el ultrasonido? Eso a mí se me ha refutado bastante en la clínica.
I don't know if I have the answer to that because it's very difficult to answer. Mostly in patients that have very non-homogeneous lungs as ARDS, there are some regions that you may not, some parts of the lung that you may not examine because of course you examine the superficial part of the lung with the lung ultrasound. So this is also something that has to be very clear, that lung ultrasound gives you the lung morphology, so suggests a potential for recruitment, but it does not tell you how much it is recruitable, and it does not tell you which is the PEEP level you should set. As we said, you always integrate the information from imaging and from other tools, but this is a limitation of lung ultrasound, but of all the imaging techniques, because also CT scan will not tell you exactly how you should set the ventilator. It just will tell you it's focal, non-focal. So this is a limitation that needs to be very clear in our mind. We do not know how to set the ventilator, and we are not sure about the setting just having a look to lung ultrasound, but we can identify morphology. This is for sure. Okay.
Okay.
Thank you, Javi.
¿Alguien más que quiera preguntar, aprovechar este momento? Juan, ¿alguna otra pregunta?
No, yo estoy bien. I'm good.
¿Estás bien?
Ya.
Ya. Estaba por ahí también la Ceci. ¿Sigue? No, parece que no.
Maybe Bruno from Brazil, Bruno Souza.
Ah,
One question from Brazil.
it's all South America.
Yes.
Peru too. Bruno from Brazil. I see. Maybe not, but because he's working in his hospital right now.
Okay.
But
Okay.
so Silvia,
Okay.
I want to give thanks for your time, your experience, and in your knowledge. If you come to Chile, you'll be more than welcome. So
I will surely do. I will
many
come.
thanks.
And I was very happy to meet you all tonight. So thanks to you all. Thanks for all the questions, and thank Javi for the invitation.
Okay. Thank you very much, Silvia. I'm sorry for the
No problems at all. It was better for me too because now it's dinner time. So
Oh, perfect. Thank you. Saludos a
see you
Francesca.
soon, dear. Okay.
Okay. Thank you.
Bye.
Bye.
Gracias, Javiera.
De
Thanks,
nada. Gracias a todos por conectarse.
Gracias por
Muchas gracias y gracias Javi y Juan Enrique. Y gracias doctora Silvia.
Gracias por la información.
Okay.
Thank you. Bye.
Bye.
Bye-bye.